Hello everyone, and welcome back to another chapter of Advanced Pharmacology. Today in Unit 12, we're talking about Chapter 51, Drugs for Erectile Dysfunction and Benign Prostatic Hyperplasia. So, speaking on medications, first on erectile dysfunction or ED. ED is defined as a persistent inability to achieve or sustain an erection suitable for satisfactory sexual performance. In the US, ED affects up to 30 million men. ED is commonly associated with chronic illness, especially diabetes, hypertension, and depression. Among men with diabetes, the incidence of ED is anywhere between 35 and 75%. Some of the drugs that can cause ED are listed here in the following table, and I'll go over these a little bit. The big ones being digoxin, risperidone, propranolol, hydrochlorothiazide, aldactone, Prozac, lithium, drinking alcohol, and finasteride. There's a couple others I didn't touch base on, but if you really need to look at the full list, hit pause. The risk for ED increases with advancing age. According to the National Institute of Health, ED affects approximately 4% of men in their 50s. Just a decade later, 70% of men in their 60s are unable to achieve any erection at all. This total inability to achieve an erection affects 47% of men older than 75 years of age. Fortunately, new advances in medicine can rectify this problem for most patients. First-line treatment for ED are lifestyle measures, meaning increased exercise and smoking cessation, changing during regimens to remove the drugs that may cause ED, and drug therapy such as Viagra or any other drug in its class. Other interventions include psychotherapy and surgical implantation of a penile prosthesis. So, the physiology of erectile dysfunction. Before discussing drugs for ED, we need to review the physiology of erection. So, as shown in the figure 51.1, the process begins with sexual arousal, which increases the parasympathetic nerve traffic to the penis, causing a local release of nitric oxide. Nitric oxide then activates the guanyl cyclase, an enzyme that makes a cyclic guanosine monophosphate. Through a series of steps, that cyclic guanosine monophosphate, or cGMP, promotes the relaxation of arterial and trabecular smooth muscle. The resultant arterial dilation increases local blood flow and blood pressure, which, in combination with the relaxation of trabecular smooth muscle, causes an expansion and engorgement of the sinusoidal spaces in the corpus cavernosum. This, in turn, causes venous occlusion and therefore reduces venous outflow. The combination of increased arterial pressure and arterial inflow plus reduced venous outflow causes sufficient engorgement to produce an erection. Erection subsides when that cGMP is removed by phosphodiesterases, type 5 or PDE5, the enzyme that converts that cGMP into a guanosine monophosphate. So here is a picture version of what we just discussed. A good spot to pause if you're unfamiliar with the pathophysiology. So, oral drugs for erectile dysfunction. The PDE5 inhibitors. Drugs for ED fall into two major groups, oral agents and non-oral agents. The oral agents are the PDE5 inhibitors, are by far the most common treatments for ED. They will constitute the primary focus. The non-oral agents, the papaverine plus phentolamine, alprostadil, are considered briefly. These drugs, again, are all summarized in the following table here. So the big ones being the PDE5 inhibitors, so your avanafil, your sildenafil, tadalafil, and vardenafil. And then we also have our prostaglandin E1s, which include our alprostadil, the intracavernosal injection, and aprostadil, the intraurethral insertion. And then finally, vasodilators, the alpha-adrenergic antagonist, which is the papaverine with phentolamine. So, again, 4 PDE5 inhibitors are available, and they include sildenafil, tadalafil, vardenafil, and avanafil. All are considered first-line therapy for ED. Current guidelines recommend that in the absence of a specific contraindication, all men with ED be offered one of these drugs. But which drug is preferred? Only a few trials have compared them head-to-head, so there is insufficient evidence to recommend one over the others. Accordingly, selection among men should be based on the patient's preference and prescriber judgment. So we can talk on the first one, and it's the most common one, sildenafil, or Viagra, which was introduced back in 1998 as the first oral treatment for ED. The drug is reliable and easy to use. Benefits derive from enhancing the natural response to sexual stimuli. Sildenafil does not cause erection directly, although sildenafil is generally well tolerated. It can be dangerous for men taking certain vasodilators, specifically the alpha-adrenergic blockers, nitroglycerin, and nitrates used for angina pectoris. So there is some patient education in regards to the PDE5 inhibitors. It's important to inform our patients that dosing may be done with or without food, although a high-fat meal will delay its absorption of avanafil, sildenafil, and vardenafil. Be sure to warn them that grapefruit juice should be avoided because again it can raise the PDE5 inhibitor level. You also want to advise patients to take avanafil approximately 15 to 30 minutes prior to sexual activity. All other PDE5 inhibitors should be taken 1 hour prior to sexual activity. Also keep in mind that you want to counsel men with pre-existing cardiovascular disease regarding the cardiac risk for sexual activity. Advise men who experience symptoms during sex to refrain from further sexual activity and to discuss the event with their prescriber. Warn patients to seek immediate medical attention if an erection lasts more than 4 hours. Prolonged priapism can cause permanent damage. Again, you need to advise patients to stop their PDE5 inhibitor and to seek immediate medical attention if they experience sudden loss of vision in one or both eyes, or if hearing loss starts to develop. Instruct patients to avoid nitrates for at least 12 hours after taking avanafil, for at least 24 hours after taking sildenafil or vardenafil, and for at least 48 hours after taking tadalafil. The erection-enhancing effects of sildenafil was discovered actually by accident. The drug was developed as a cardiac medicine, but benefits were minimal. However, in the course of testing, some men noticed a surprising side effect. Their ED had been cured. The rest, as I say, is history. Sildenafil has been wildly popular. First-year sales were the hottest in pharmaceutical history. By now, tens of millions of men in more than 100 countries have used the drug. The addition to ED, sildenafil is approved for pulmonary arterial hypertension. When used for this purpose, sildenafil is sold as a medication by the name of Revatio. So how does it actually work? Well, sildenafil causes selective inhibition of PDE5. By doing so, it increases the preserved's cGMP levels in the penis, thereby making the erection harder and longer lasting. Again, please note that the drug only enhances the normal erectile response to sexual stimuli. In the absence of a sexual stimuli, nothing happens. So, its pharmacokinetics. Sildenafil is well absorbed after oral administration. Bioavailability is about 40%. In fasting subjects, plasma levels peak after about 1 hour after dosing. A high-fat meal will slow absorption, resulting in a peak plasma level in about 2 hours, and reducing the peak concentration. Sildenafil is metabolized in the liver, primarily by the 3A4 isoenzyme, or cytochrome P450. Both the parent drug and its major metabolite are biologically active. Both compounds are eliminated primarily in the feces and partly in the urine. For both compounds, the half-life is 4 hours. Clearance of both is delayed in men older than the age of 65 and in men with hepatic impairment or severe renal insufficiency, causing drug levels to rise higher and to persist longer. So, sexual benefits then in men with ED. Sildenafil has been evaluated in several thousand men between the ages of 19 to 87 with ED of organic, psychogenic, and mixed cause origin. At least some improvement in erection hardness and duration was seen in about 70% of men taking the medicine, compared with the 20% taking a placebo. Benefits were dose-related and lasted up to 4 hours, although they began to fade after 2. Sildenafil was able to help a wide range of patients, including those with ED resulting from diabetes, spinal cord injury, and transurethral prostate resection, as well as ED of no known physical cause. So, in men without ED, despite the anecdotal report to the contrary, sildenafil has little or no effect on erection quality or duration in men who do not have ED. Any apparent benefits in healthy men are likely the result of a placebo response. In women, sildenafil is not approved for use in women and probably won't be, although several large-scale studies showed the drug is safe in women. They failed to show much enhancement of sexual arousal. Thus, the manufacturer decided to seek the FDA's approval for treating female hypoactive sexual desire disorder or any other condition in women. So, its adverse effects then. There are drugs for erectile dysfunction here, and this patient-centered care across the lifespan. Again, it's up to you if you want to hit pause here and read through it entirely. We'll discuss most of the adverse effects though. The first being hypotension. At a recommended dose, sildenafil produces a small reduction in blood pressure. However, in men taking nitrates or alpha blockers, severe hypotension can develop. Priapism. A few cases of priapism, which is a painful erection that lasts more than 6 hours, has been reported. If an erection persists for more than 4 hours, immediate medical intervention is required. If left untreated, priapism can cause permanent damage of penile tissue. If priapism persists longer than 24 hours, chances are very high that the patient will never be able to have sexual intercourse again. Persistent erection can be relieved by aspirating blood from the corpus cavernosum, followed by irrigation with a solution containing a vasoconstrictor. If this is unsuccessful, surgery may be required. Side effects of the non-arteritic ischemic optic neuropathy. Very rarely, men who are taking sildenafil may develop NAION, resulting in irreversible blurring or loss of vision. The cause is blockage of blood flow to the optic nerve. In most cases, there was underlying anatomic or vascular risk factors for NAION. Although NAION developed during sildenafil use, a direct causal relationship was not established. Nonetheless, patients with NAION in one eye should not use sildenafil owing to the potential risk for developing it in the other eye. Sudden hearing loss, another adverse effect. Very rarely, men taking sildenafil have experienced sudden hearing loss, usually in 1 year, sometimes in association with dizziness, vertigo, and tinnitus. Hearing loss may be partial or complete. Hearing returned by the time the loss was reported in 1/3 of cases, but had not returned in the remaining 2/3. To date, a direct causal relationship between sildenafil and hearing loss has not been established. Nonetheless, the drug is suspected because sudden hearing loss is unusual and it developed when sildenafil was taken. Men who experience sudden hearing loss should discontinue the drug, but only if they are taking it for ED. Men who are taking the drug for PAH should continue treatment. And that leads us to other adverse effects. The most common adverse effects include headaches, flushing, and dyspepsia. Sildenafil may also cause nasal congestion, diarrhea, rash, and dizziness. About 3% experience a mild transient visual disturbance, mostly a blue color tinge to vision, increased sensitivity to light, and blurring. In addition, sildenafil may intensify symptoms of OSA. And then there are also adverse effects due to other drug interactions, the most being with nitrates. Both sildenafil and nitrates promote hypotension, and they both do so by increasing that cGMP. If these drugs are combined, there is a life-threatening hypotension that could result. Therefore, sildenafil is absolutely contraindicated in any man who takes a nitrate. At least 24 hours should elapse between the last dose of sildenafil and giving a nitrate. If elimination of sildenafil is slowed, an even longer time should elapse before a nitrate is used. Which brings us here to our prototype drugs that we will be talking about. It's a good spot to hit pause, but keep in mind we will be discussing each of these in order. So, another adverse effect when sildenafil is used with alpha blockers. Alpha-Adrenergic antagonists, which include doxazosin and other alpha blockers used for prostatic hyperplasia, dilate arterioles and can thereby lower blood pressure. Combined use with sildenafil has caused symptomatic postural hypotension. So again, these combinations should be used with caution. And finally, adverse effects with other inhibitors of the CYP3A4. Any other kind of inhibitor of CYP3A4 can suppress metabolism of sildenafil, thereby increasing its levels. So these combinations need to be used with caution. So, is sildenafil still safe for men who have coronary artery disease? Reports of adverse cardiovascular events, including at least 130 cardiac deaths, raised concern about the safety of sildenafil in men who had coronary heart disease, or CHD. However, there was a question as to what caused the adverse effect, sildenafil or the sexual activity that sildenafil permitted. When attempting to answer this question, researchers made two important observations. First, giving sildenafil to resting men with severe CHD produced no harmful effects on coronary blood flow or any other hemodynamic parameter. Second, in men with stable CHD who were performing exercise, again, sildenafil had no effect on CHD symptoms, exercise tolerance, or exercise-induced ischemia. Taken together, these results suggest that in men who have CHD, sexual activity and not sildenafil is the likely cause of ischemic events. However, even though sildenafil itself appears safe in men with CHD, sexual activity may not be. So accordingly, the drug should be used with caution by men with the following conditions: past or present myocardial infarctions, strokes, or life-threatening dysrhythmias in the past 6 months, resting hypotension, resting hypertension, heart failure, and unstable angina. So, in addition, sildenafil should not be used at all by any man who is taking nitroglycerin or any other drug in the nitrate family. So, to reduce the risk for adverse events, candidates for sildenafil therapy should undergo a careful evaluation of cardiovascular function. Those who have impaired function should be counseled about the risk posed by sexual activity and all other moderate to intense physical activity. Which brings us now to vardenafil, tadalafil, and avanafil. All three are very similar to sildenafil. All three drugs inhibit that PDE5, and all three are approved for oral therapy of ED. Vardenafil is unique in that it prolongs the QT interval, and tadalafil is unique in that its effects can last up to 36 hours. Avanafil is unique in that it has the fastest onset of action. Otherwise, the clinical effects of all four medications are equal, although some patients may respond better to one over the others. Properties are shown here in the following table on how they may compare. So here's an excellent spot to hit pause, and you can take a look at all the different dosages and their half-life, onset, what have you. So I'll leave that up for just a moment. Vardenafil. Its action and use. Vardenafil, also known as Levitra or Staxin, was approved back in 2003, which was the second selective PDE5 inhibitor released for ED. As with sildenafil, benefits derive from relaxing arterial and trabecular smooth muscle in the penis. Effects begin in about 60 minutes after dosing and can last for up to 4 hours. There's no evidence that vardenafil works faster, longer, or better than sildenafil. Its pharmacokinetics, therefore, oral bioavailability, is actually pretty low, only about 15%, and is decreased further if you're having a high-fat meal. Plasma levels peak in about 1 hour after dosing, or after 2 hours if dosing is done with a high-fat meal. Vardenafil again undergoes extensive metabolism by the hepatic CYP3A4, followed by the excretion primarily in the feces. The half-life is 4 to 5 hours. Its adverse effects, the most common being a headache, flushing, and rhinitis. Like other PDE5s inhibitors, vardenafil can lower blood pressure. Vardenafil can also cause visual changes and has been associated with sudden hearing loss and vision loss from NAION. Vardenafil also again has the opportunity or has the side effect of causing a QT interval prolongation and might therefore pose a risk for serious dysrhythmias. However, dysrhythmias have not been reported. Nonetheless, to reduce the risk, vardenafil should be used with caution in any patient that's taking other medications that also prolong the QT interval. Other drug interactions. Vardenafil is contraindicated for use with alpha-adrenergic blockers and with nitroglycerin and other nitrates. Again, plasma levels can be increased by inhibitors of CYP3A4, and therefore these combinations must be used with caution. As noted, caution is also needed in patients taking drugs that again prolong that QT interval. Which brings us to tadalafil. Tadalafil, also known as Cialis, was approved mere months after vardenafil, and similar to sildenafil and vardenafil, the drug is indicated for oral therapy of ED. As with other PDE5 inhibitors, the benefits derive from the relaxation of penile, arterial, and trabecular smooth muscle, brought on by accumulation of cGMP. On average, therapeutic levels of the drug are reached by 2 hours after dosing and can persist about 36 hours, which is much longer than either of the other two drugs. As a result, timing and dosing of sexual activity needn't be tightly coupled. Furthermore, in addition to being approved for as-needed dosing, tadalafil is also approved for daily dosing. As discussed, tadalafil is also used for BPH. So in addition, similar to sildenafil and tadalafil, Sultan as Adcirca is also used for PAH. Which brings us to its pharmacokinetics. Absorption rate is variable, but unaffected by food. Plasma levels peak in half an hour to 6 hours after dosing and starts to slowly decline after that. Tadalafil undergoes a metabolism by the hepatic CYP3A4, followed by the excretion in the feces. Its drug half-life is 17.5 hours. Adverse effects. The most common adverse effects are again the headache, dyspepsia, back pain, myalgia, limb pain, flushing, and nasal congestion. Like all the other PDE5s inhibitors, tadalafil can lower blood pressure. Very rarely, the drug alters color vision. A few cases of NAION and sudden hearing loss, however, have been reported, but a causal relationship wasn't fully established. Because tadalafil has a long duration of action, adverse effects may persist for many hours. Its drug interaction, therefore, tadalafil again is contraindicated in patients who are taking nitrates or alpha blockers, except for one medication, which is tamsulosin, also known as Flomax. As with sildenafil and vardenafil, CYP3A4 inhibitors can cause levels of tadalafil to rise. To avoid toxicity, men who are taking CYP3A4 inhibitors need to limit their tadalafil dosage to about 10 milligrams every 72 hours. So, it's as needed dosing. The manufacturer does not identify a minimum time between dosing and sexual activity. However, because the blood levels peak more slowly than with sildenafil or vardenafil, allowing for at least 1 hour for absorption would seem reasonable. Dosage should be reduced in men with moderate renal or hepatic insufficiency. Men with severe hepatic insufficiency should not use tadalafil. For men who are taking CYP3A4 inhibitors, again, the maximum dose needs to be 10 milligrams every 72 hours. That's for PRN dosing. Now for daily dosing. Daily dosing is recommended only for men who anticipate sexual activity at least twice a week. The medication should be taken at the same time each day. Which brings us to avanafil, the last of the PDE5 inhibitors. Avanafil, also known as Stendra, it was approved in 2012, and that is the latest selective PDE5 inhibitor approved for ED. Actions are the same for the other PDE5 inhibitors. However, effects can begin within 15 minutes after dosing and last up to 2 hours. So, its pharmacokinetics, therefore, absorption is rapid, with an onset of about 15 minutes. The plasma levels peak in about 30 to 45 minutes after dosing in fasting patients, or in about 1.25 hours if taken with a high-fat meal. Again, as with any other PDE5 inhibitor, metabolism occurs by CYP3A4. There is also less metabolism by the CYP2C isoenzymes. Excretion is through the feces and about 20% in the urine. The drug's half-life is about 5 hours. There are adverse effects. Headache is the only adverse effect, occurring in at least 10% of patients. A few patients will experience flushing, nasal congestion, and nasopharyngitis. And like other PDE5 inhibitors, avanafil may lower blood pressure. So its drug interactions. Avanafil again is contraindicated for anyone who is on a nitroglycerin or nitrate. It can increase the hypertensive effects of alcohol and antihypertensive drugs, especially alpha-adrenergic antagonists. A starting dose of 50 milligrams is recommended if prescribed for a patient who's taking antihypertensive drugs. Plasma levels can be increased when taken with a CYP3A4 inhibitor. For that reason, dosing should not exceed 50 milligrams in 24 hours for those patients who are on a CYP3A4 inhibitor. Which brings us now to the non-oral drugs for ED. Unlike the PDE5 inhibitors, which are administered orally, the drugs discussed in this section, your alprostadil and papaverine and phentolamine, are administered by the non-oral route. Specifically, they are administered either by injection into the penis or by insertion into the urethra. Because of this inconvenient dosing, this drug is considered second line for ED. So, we'll talk about the first one, alprostadil, or prostaglandin E1, the transurethral. Alprostadil pellets, also known as Muse, is the only ED drug that is approved for twice daily use. It is inserted into the urethra. Administration is accomplished by loading a pellet into the small plastic applicator, which is then inserted 1.5 inches into the urethra. Detailed instructions for the insertion are available in the package insert. Both the package insert and training video are available online. The erection starts to develop 5 to 10 minutes after the drug insertion and lasts anywhere between 30 to 60 minutes. Dosage is determined in the provider's office, and objective is to employ the smallest dose required to produce an erection sufficient for intercourse. So how does it actually work? Its mechanism of action of alprostadil's active ingredient has the same chemical structure as prostaglandin E1, which has vasodilating properties, the relaxation of smooth muscle, causing a rapid inflow of arterial blood. As explained when discussing the physiology of an erection, the blood fills the vascular sinusoidal spaces of the corpora cavernosa, resulting in an erection. Pressure from the engorged penis then helps block venous outflow to promote maintenance of the erect state. However, this option has adverse effects, the most common of which is the effect of a dull ache in the penis, which occurs in about 32% of users. Another 12% report urethral burning. Minor bleeding or spotting and testicular pain occur in about 5% of patients. Systemic symptoms are considered rare when taken as directed and approximately those of placebo use. Which brings us then to the intracavernous. Alprostadil, also known as Caverject or Caverject Impulse or EDEX, is also available in a form of direct injection into the corpus cavernosum. Again, there's a training video demonstrating how to inject the medication, plus a link to access written instructions on this website here. The response is rapid, and the injection is relatively painless. Optimal dosage is determined in the prescriber's office. The dosing endpoint is an erection that is sufficient for intercourse, but that does not last for more than 1 hour. Injectable alprostadil should be used no more than 3 times a week, and not more than once in 24 hours. Acute adverse effects are the burning sensation, prolonged erection, and priapism. Penile fibrosis may develop with continued use. And that brings us to the last one, which is the papaverine plus phentolamine. This combo drug can provide tumescence when injected directly into the corpus cavernosum. Erection develops within 10 minutes and lasts anywhere between 2 to 4 hours. In clinical trials, erection suitable for intercourse was produced in 65% to 100% of males with ED of neurologic or vascular origin. As with the other drugs for ED, papaverine and phentolamine produce erection by increasing arterial inflow to the penis and decreasing venous outflow. Arterial inflow is augmented by alpha-adrenergic blockade and by the direct relaxant action of papaverine on arterial smooth muscle. That, however, leads us to its adverse effects, the main one being priapism, which occurs in about 10% of patients. Development of painless fibrotic nodules in the corpus is common. Other adverse effects included orthostatic hypotension with dizziness, transient paresthesias, ecchymosis, and difficulty in achieving an orgasm or ejaculation. Papaverine and phentolamine are not approved by the FDA for the treatment of ED, and many experts in the field do not recommend their use. Again, as mentioned, there are some significant adverse effects. Also, these drugs come from compounding pharmacies. In light of numerous FDA recalls from compounding pharmacies in recent years, some providers still have concerns about the safety and quality issues as well. So then there are clinical guidelines for the management of erectile dysfunction. There's several websites listed here. Go ahead and hit pause and take a look. Which leads us now to the advanced pathophysiology for the assessment for sexual dysfunction. Another spot to hit pause so you can take a look at how do we figure out how to best manage ED. And that brings us to the opposite end now of our issues here, and that is benign prostatic hyperplasia, also known as BPH. And that is a common condition that develops in more than 50% of men by the age of 60 and 90% of men by the age of 85. Although BPH and prostate cancer can coexist, there's no evidence that one predisposes one to the other. So what exactly is it? The pathophysiology and overview of the treatment. The prostate is a heart-shaped gland that surrounds the male urethra. Its major function is to produce fluids that contribute to the ejaculate volume. In a healthy man, the prostate is walnut-sized and weighs anywhere between 4 and 20 grams. In men who have BPH, prostate mass may reach as much as 50 to 80 grams. BPH is a non-malignant prostate enlargement that caused by excessive growth of epithelial cells and smooth muscle cells. Overgrowth of the epithelial cells causes mechanical obstruction of the urethra, whereas overgrowth of smooth muscle causes dynamic obstruction of the urethra. In men with BPH, the ratio of epithelium to smooth muscle varies anywhere from 1 to 3 to 4 to 1. In general, the larger the prostate, the higher the percentage of the epithelium. Signs and symptoms of BPH include urinary hesitancy, urinary urgency, increased frequency of urination, dysuria, nocturia, straining to void, post-void dribbling, decreased force and caliber of the urinary stream, and a sensation of an incomplete bladder. There is no direct correlation, again, between symptoms and prostate size. Therefore, some men with only a moderate enlargement may be highly symptomatic, whereas others with a substantial enlargement may have no symptoms. Long-term complications, however, of BPH may include obstructive nephropathy, bladder stones, and recurrent UTIs. Which leads us to our treatment modalities. BPH can be managed in 3 ways. There's invasive treatments, drug therapy, and watchful waiting. Invasive options include a transurethral resection of the prostate, laser prostatectomy, transurethral electrovaporization of the prostate, and a transurethral microwave therapy. These procedures are most appropriate for men with severe symptoms or complications. Drugs are indicated for men with a moderate symptom list. And finally, watchful waiting, which consists of annual reevaluation with reconsideration of management based on results, is appropriate for men with minimal symptoms. So, drug therapy for BPH. BPH can be treated with 2 major classes of drugs. We have our 5-alpha reductase inhibitors and our alpha-adrenergic antagonists. With both, the goal is to relieve bothersome urinary symptoms and delay disease progression. The 5-alpha reductase inhibitors are most appropriate for men with very large prostates, whereas the alpha blockers are preferred for men with relatively small prostates. Major drugs for BPH are shown here in the following table, and the preparation, dosing, and administration of both drugs for BPH is provided in the next table. So here are 2 tables. It's an excellent spot to hit pause. So the first one has the drugs for BPH, which again can be our 5-alpha reductase inhibitors, our alpha-1 blockers, our non-selective alpha-1 blockers, and the alpha-1A blockers / 5-alpha reductase inhibitors. And then there's drugs for BPH, their preparation, dosage, and administration. Again, a good spot to hit pause. Again, it has that alpha-1 adrenergic antagonist, the 5-alpha reductase inhibitors, the PDE5 inhibitors, and combo drugs. So, we'll speak on the 5-alpha reductase inhibitors first. There are 2 5-alpha reductase inhibitors that are available. The most common one today is finasteride. The other one is dutasteride. Both drugs can reduce prostate size, although several months are required for a noticeable effect. There currently is no proof that one drug works better than the other, but it's now 2025 and the drug of choice is finasteride. Finasteride, also known as Proscar, acts in reproductive tissue to inhibit 5-alpha reductase, an enzyme that converts testosterone to the dihydrotestosterone, the active form of testosterone in the prostate. Treatment reduces levels of DHT in blood by 70%. By decreasing DHT availability, finasteride promotes regression of prostate epithelial tissue and therefore decreases mechanical obstruction of the urethra. Because the percentage of epithelial tissue is highest in very large prostates, finasteride is most effective in men whose prostates are highly enlarged. Conversely, the drug confers less benefit if the degree of enlargement is small. Be aware that prostate shrinkage occurs slowly, usually over a period between 6 to 12 months. By reducing levels of DHT, finasteride may protect against prostate cancer, but only cancers classified as low grade. Finasteride does not protect against high-grade prostate cancers. In fact, when given to a healthy man to prevent prostate cancer, finasteride actually increased the likelihood of a high-grade tumor. So, according to the Oncology Drugs Advisory Committee of the FDA, it recommends against allowing the manufacturer to label finasteride as a drug for prostate cancer prevention. Finasteride is generally well tolerated. However, 5 to 10% of patients, it decreases ejaculate volume and libido. In addition, gynecomastia develops in some men. Finasteride is classified by the FDA pregnancy risk category X because it is teratogenic to the male fetus. Finasteride is contraindicated for women who are pregnant or may become pregnant. In addition, because finasteride can be absorbed through the skin, pregnant women should not handle tablets that have been broken or crushed. Men are also advised not to donate blood if they are taking finasteride or until at least 1 month after stopping the drug to avoid the risk of having a pregnant woman be the blood recipient. Finasteride decreases serum levels of prostate-specific antigens, a marker for prostate cancer. The expected decline is 30 to 50%. PSA levels should be determined before the treatment and 6 months later. If the PSA levels do not fall as expected, the patient should be evaluated for cancer of the prostate. For the treatment of BPH, therapy continues for life. As discussed in Chapter 86, the drug is also available in 1 milligram tablets sold as Propecia for the treatment of male pattern baldness. Which brings us to its other medication, dutasteride. Dutasteride, or Evodart, is similar to finasteride in most respects. However, there are 2 important differences. First, the reduction in circulating DHT is more complete. And second, it has an extremely long half-life, which is about 5 weeks. Therefore, it can take months to clear the drug after dosing has stopped. Similar to finasteride, dutasteride inhibits 5-alpha reductase and therefore suppresses the production of DHT. However, whereas finasteride inhibits only the form of 5-alpha reductase found in the reproductive tissue, dutasteride also inhibits a form found in the skin and liver. So as a result, it produces a greater reduction in circulating DHT, which is about 93% versus the 70%. Whether this translates to a greater clinical response has not been established because dutasteride and finasteride have not been directly compared. Dutasteride is generally well tolerated. However, it does reduce ejaculate volume and libido in some men and causes a decline in PSA in all men. Similar to finasteride, dutasteride is classified by the FDA pregnancy risk category X. Again, it can be absorbed through the skin, so women should not handle the drug. And again, men should not donate blood if they are taking this medication for at least 6 months after stopping, again to avoid a transmission to women through an infusion. And that's because, again, it has that prolonged half-life. Dutasteride can also reduce the likelihood of a low-grade prostate tumor, but it increases again the likelihood of a high-grade prostate tumor. The drug should therefore not be used for prostate cancer prevention. Although many capsules can be opened and sprinkled on food, this is not the case with dutasteride. The capsule contents can be irritating to the oropharyngeal mucosa. Therefore, the capsule must be swallowed whole with a full glass of water. And that brings us to our alpha-adrenergic antagonists. 5 alpha blockers are approved for BPH: alfuzosin, terazosin, doxazosin, silodosin, and tamsulosin. These drugs have not been directly compared in clinical trials, so we can't say whether one is more effective than others. However, 2 newer ones, silodosin and tamsulosin, may be tolerated better. The pharmacology of these drugs are discussed in Chapter 14, so the discussion here is limited to the use strictly in BPH. So how does it work? The blockade of the alpha-1 receptor reduces smooth muscle in the bladder neck, prostate capsules, and prostatic urethra, thereby decreasing a dynamic obstruction of the urethra. Symptomatic improvement and increased urinary flow develop rapidly. Because dynamic obstruction is the major contributor to symptoms in patients with relatively mild prostatic enlargement, alpha blockers are preferred to 5-alpha reductase inhibitor for these men. To maintain the benefits, alpha blockers must be taken lifelong. Unlike the 5-alpha reductase inhibitors, the alpha-1 blockers do not reduce prostate size. So, receptor specificity and impact on blood pressure. The alpha blockers differ regarding specificity of receptor blockade and resultant effects on blood pressure. Specifically, whereas silodosin and tamsulosin are selective for alpha-1A receptors, alfuzosin, terazosin, and doxazosin are non-selective alpha-1 blockers, and therefore block alpha-1 receptors in blood vessels as well as the alpha-1A receptors in the prostate. By blocking alpha-1 receptors in blood vessels, the 3 non-selective agents promote vasodilation and can therefore lower blood pressure. In fact, 2 of these drugs, doxazosin and terazosin, were developed as an antihypertensive agent. Their use in BPH came later. Because of their effects on blood pressure, the non-selective alpha-1 blockers are especially useful for patients who have hypertension in addition to BPH, but may be dangerous for men with reduced blood pressure. Conversely, because silodosin and tamsulosin has little or no effect on blood pressure, there are no benefits to men with hypertension, but are preferred if reducing blood pressure would be a problem. So, its adverse effects. Again, here is a section on patient-centered care across the lifespan regarding drugs for benign prostate hyperplasia. Again, it's a good spot to hit pause so you can go ahead and take a look. The alpha-1 blockers are generally well tolerated. For the non-selective agents, your alfuzosin, doxazosin, terazosin. Principal adverse effects are hypotension, fainting, dizziness, somnolence, and nasal congestion. Because silodosin and tamsulosin have minimal effects on vascular smooth muscle, these drugs are less likely to cause hypotension, fainting, dizziness, or nasal congestion. However, silodosin and tamsulosin can cause abnormal ejaculation, whereas the non-selective agents do not. In contrast to dutasteride and finasteride, alpha blockers do not reduce levels of PSA. For men undergoing cataract surgery, alpha blockade increases the risk for intraoperative floppy iris syndrome, a complication that can increase post-op pain, delayed recovery, and reduce the hoped for improvement in vision acuity. In severe cases, the syndrome can cause defects to the iris that may lead to blindness. Men anticipating cataract surgery should postpone alpha blocker therapy until after the procedure. Men already taking an alpha blocker should be sure to tell their ophthalmologist. So, drug interactions. Exercise caution when combining non-selective alpha blockers with other drugs that may lower blood pressure. Excessive hypertension again may result. Drugs of concern include our organic nitrates, antihypertensive drugs, and the PDE5 inhibitors, again used for ED. Strong inhibitors of CYP3A4, such as erythromycin, itraconazole, nefazodone, and HIV protease inhibitors, can dramatically increase levels of alpha-systosin and silodosin. Accordingly, alpha-systosin and silodosin must not be combined with these drugs. Their use in women, therefore. Tamsulosin and other alpha blockers are being used off-label to treat women with urinary hesitancy and urinary retention associated with a bladder outlet obstruction or insufficient contraction of the bladder detrusor muscle. Benefits derived from relaxing smooth muscle in the bladder neck and urethra. Maximal improvement may take several weeks to develop. Which brings us now to the alpha-1 blocker / 5-alpha reductase inhibitor combo. In clinical trials, combining an alpha blocker with a 5-alpha reductase inhibitor has been superior to the treatment with either agent alone. Because alpha blockers and 5-alpha reductase inhibitors work by different mechanisms, it is not surprising that combining them has been helpful. The alpha blocker can provide rapid symptomatic relief, while over time, the 5-alpha reductase inhibitor can provide additional symptomatic relief and may also delay disease progression. Research has demonstrated effectiveness with tamsulosin plus dutasteride and doxazosin plus finasteride. Presumably, the combination of the alpha blocker with the 5-alpha reductase inhibitor would also be effective. If a single dose is preferred, tamsulosin plus dutasteride is available. Which brings us back to that PDE5 inhibitor tadalafil, also known again as Cialis, is approved for men who have BPH by itself or BPH combined with ED. In men with BPH, tadalafil produces a modest decrease in symptoms, but does not improve urine flow rate. Furthermore, only 1 in 6 men may benefit from the medication. Initial improvement is seen in 2 weeks. So how does tadalafil help? Possibly by relaxing smooth muscle in the prostate, bladder, and urethra. Although tadalafil is the only PDE5 inhibitor approved for ED, other PDE5 inhibitors can reduce symptoms as well. Owing to the risk for hypotension, however, tadalafil should be used with caution in men taking an alpha blocker and should be avoided in any man taking a nitrate. Which brings us now to the other drugs for BPH. Starting us off with anticholinergics. Symptoms of overactive bladders, such as urgency and frequency, are often experienced by men who have BPH. Anticholinergic drugs are helpful when this occurs. Those approved for an overactive bladder include darafenacin, fesoterodine, oxybutynin, solifenacin, tolterodine, and trospium. These may be used alone or in combination with an alpha blocker, such as Flomax, to improve urinary symptoms, which were already discussed in Chapter 12. Botulinum toxin, or Botox, a well-known remedy for facial wrinkles, can also help men with BPH. A single injection into the prostate can relieve urinary symptoms for almost up to 1 year. Benefits derive in part by blocking the release of acetylcholine from neurons that innervate urinary tract smooth muscle. However, because the drug also reduces both prostate size and blood levels of PSA, other mechanisms must also be involved. Complementary and alternative medications for BPH. Sal palmetto is a herbal preparation used widely to treat BPH despite numerous randomized controlled trials that refuted findings of earlier less rigorous studies. In 2012, a Cochrane review of 32 RCTs involving 5,666 men found no significant difference between sal palmetto and a placebo, even at doses 2 to 3 times the usual dose. What about other CAMs, therefore? In the latest clinical guidelines, the American Urology Association declined to recommend any dietary supplement or herbal treatment, which included saw palmetto, until there is a sufficient body of evidence from rigorous clinical trials to support their use. Clinical guidelines for the management of BPH. The American Urology Association updated their clinical guidelines for the management of BPH. The following figure here helps break that down a little bit. So here is an excellent spot to hit pause so you can see the management of symptomatic benign prostatic hyperplasia, as well as overactive bladder. Which brings us now to the prescribing and monitoring considerations of PDE5 inhibitors. The nursing implications that follow pertain only to the use of PDE5 inhibitors for ED, not for their use in pulmonary arterial hypertension. So, the therapeutic goal of a PDE5 inhibitor is to use to enhance both the hardness and duration of erection in men with ED. It's important to have some baseline data. Evaluate patients for cardiovascular disorders, including strokes, hypertension, heart failure, unstable angina, MIs, and recent history of any kind of severe dysrhythmia. Identifying high-risk patients, PDE5 inhibitors are again contraindicated in any man who is taking a nitrate, such as nitroglycerin, and should generally be avoided by men taking alpha blockers. Avoid vardenafil, but not sildenafil or tadalafil, in men taking a class 1 or class 3 antidysrhythmic drug. The use of PDE5 inhibitors with caution in men who are on CYP3A4 inhibitors and in those with NAION, coronary heart disease, and other cardiovascular disorders. Keep in mind as well its administration consideration. Dosing with food. Again, these drugs may be taken with or without food. However, a high-fat meal will delay absorption of avanafil, sildenafil, or vardenafil. Grapefruit juice may also decrease metabolism, resulting in a higher than recommended drug level. Other administration considerations again are the timing of dose. All PDE5 inhibitors may be used as needed. Avanafil should be taken approximately 15 to 30 minutes before any sexual activity. All other PDE5 inhibitors should be taken about 1 hour prior to sexual activity. Only tadalafil is approved for daily dosing. And then other ongoing evaluation and intervention. Again, it's all about minimizing adverse effects on cardiac risk for men with pre-existing cardiovascular disease. Consider carefully the cardiac risk associated with sexual activity before prescribing a PDE5 inhibitor or any drug for ED. The risk for priapism. Again, PDE5 inhibitors can cause priapism, which can result in a permanent ED owing to the local tissue damage. Treatment, which must be instituted promptly, involves aspiration of blood from the corpus cavernosum, followed by the irrigation with a vasoconstrictor. Non-arteritic ischemic optic neuropathy, again that NAION. Very rarely, men taking PDE5 inhibitors have developed NAION, with resultant irreversible blurring of vision or blindness, so it's important that we monitor for vision changes with each refill. And then lastly, sudden hearing loss. Very rarely, men taking PDE5 inhibitors have developed sudden loss of hearing. Sometimes, again, it's associated with dizziness, vertigo, and tinnitus, so we need to monitor for hearing changes with each refill as well. And then lastly, it's important that we are minimizing adverse interactions when taken with nitrates. Again, combining a PDE5 inhibitor with a nitrate can cause a severe drop in blood pressure. Concurrent use of these drugs is contraindicated. Your alpha-adrenergic blockers. Combining the PDE5 inhibitor with an alpha blocker can cause a serious drop in blood pressure. To avoid harm, use caution when combining sildenafil or avanafil with an alpha blocker. And do not combine tadalafil with any alpha blocker, except tamsulosin. And do not combine vardenafil with any alpha blocker at all. And then again, inhibitors of CYP3A4. Agents that inhibit CYP3A4 can raise the PDE5 level. So to avoid harm, dosage of that PDE5 inhibitor needs to be reduced. And lastly, antidysrhythmic drugs. Avoid prescribing vardenafil for men who are on any kind of class 1 or class 3 antidysrhythmic drug. Vardenafil prolongs the QT interval and can therefore cause a severe dysrhythmia when combined with these drugs. That completes our chapter here for today. I thank you as always for listening, and I hope you have a wonderful rest of your day. Thank you, and have a good one. Bye-bye.